Hello, I'm here to present on somatic symptom disorder. Somatic symptom disorder can be found on page 351 of the DSM-5 TR. Let's go ahead into introduction. Clients with somatic symptom disorder experience significant amounts of distress and dysfunction, and they tend to spend most of their time and emotional energy on dealing with these somatic symptoms that arise from their body. It tends to, like I said, cause significant distress and function to the extent where they're unable to carry out their regular life activities. Physical symptoms may or may not be explained by a medical condition that can be diagnosed by a medical practitioner, such as a doctor or nurse or medical professional. The previous versions of the DSM said that this diagnosis could not be provided to a client unless these somatic symptoms were clinically explained. However, revisions have been made to support primary care providers in labeling undiagnosable medical conditions, which means that these symptoms arise, but they don't really have a medical illness causing them, and it's specifically arising from the body without a specific causal effect. Coming to the etiology of somatic symptom disorders. So somatic symptom disorders create a really high sense of awareness within their clients' bodies. So clients consistently feel sensations in their bodies. And obviously, in the medical world that we're in, they're inclined towards making or interpreting these symptoms as a medical illness. The risk factors include childhood neglect, sexual abuse, a chaotic lifestyle, substance abuse. All in all, to me, it feels like almost all kinds of trauma can cause somatic symptom disorder. And this generally includes access to personality disorders and can be associated with some of these disorders, which include avoidant, paranoid, self-defeating, and obsessive-compulsive disorder. Psychosocial stressors can also contribute towards somatic symptom disorder. So employment or occupational functioning can also be implicated. In terms of characteristics and the populations that it affects, it tends to affect 5 to 7% of the general population, and there seems to be a higher occurrence in females. Generally, the somatic symptom disorder occurs during childhood and adolescence, and I can't help but think about the developmental trauma that we experience growing up and how it carries on as adults. And we experience its manifestation as adults and then try to seek answers through therapy. 17% of primary care providers come across somatic symptom disorders, and often they can be confused as things like irritable bowel syndrome or chronic fatigue syndrome. And usually they encompass functional disorders. So things like fibromyalgia might also be prevalent. Next, we can talk about the pathophysiology. So because somatic symptom disorder is not a clinical condition, when I say clinical, I mean like within the primary care setting. Its origins are unknown, but it tends to cause autonomic arousal or endogenous or noradrenergic compounds. So what that means is the limbic system of your brain gets activated, causing your body to react in certain ways, thereby creating symptoms that tend to recur. And because they're recurrent and persistent, the client will assume that they're experiencing a certain health-related illness, and then seek out help at hospitals with doctors or in the ER. Usually, this would cause tachycardia, which means your heart rate starts to increase, gastric hypermobility, that means excessive amounts of gas. It can be confused to be gastritis or just digestive issues in general. And then there's also a heightened sense of muscle arousal. So whether it's tense muscles, whether it's tingling, there are different sensations that are experienced by the body on a frequent or almost chronic basis. And also, their studies show that this might be epigenetic in nature, which means I can't help but think about how trauma can live on within a person's neurobiology and system and can get passed on from generation to generation. And it's only when one recognizes that they're experiencing these chronic symptoms that they try and seek out help, usually within the medical healthcare system, and then coming into the body and mind and trying to figure out what's going on psychologically. So diagnosing, the three requirements are there to fulfill the diagnostic criteria for somatic syndrome disorders. Significant distress and disruption of daily living, thoughts of somatic symptoms that are persistent and excessive, along with high amounts of anxiety. And the symptoms need to be present for at least more than 6 months. So, diagnosing, just from the previous um, points that I shared, it's obvious that it can definitely be confused with other diagnoses that exist within the DSM. So it's really, really important to do an extremely thorough history and a full review of systems. And to me, I feel like we need to do a family systems along with a physical exam to rule out the fact that it's not a physical condition that's causing these somatic complaints. Apart from that, an MSE, the mental status exam, should be performed almost every session, of course, as we know, but essentially in the first few sessions, you want to take note of the appearance, the affect, memory, concentration, orientation, whether there's any hallucinations or delusions, suicidal tendencies, homicidal ideation, because this helps to give a more robust view of specifically what the client is experiencing, and then also will help in the differential diagnosis, which we will come to in a little bit. The treatment. So, usually the pharmacologic approaches to the treatment of this disorder should be limited, which means that the client should not be over medicated. Antidepressants have set to help in the treatment of psychiatric comorbidities. I that include anxiety, depressive symptoms, and obsessive compulsive disorder. The prescription of SSRI, that's selective serotonin reuptake inhibitors, or SNRI, that's selective norepinephrine reuptake inhibitors, has set to help with the reduction of the occurrence of symptoms. However, it's advised that the medication should be kept to a minimal dose in order to allow the client's body to adjust to the medication that they're taking. And specifically because it's so somatic in nature and it involves the body experiencing multiple sensations, increased medication might throw the client off of their usual threshold and also create adverse effects in the treatment, which creates a cause of concern. And then we can move into the differential diagnosis. As I mentioned earlier, it's important to use the MSC and have a thorough history to rule out what this diagnosis is not first. So, non-specific symptoms may mimic presentation of medical illnesses. So, that's one thing that makes diagnosing this particular diagnosis very tough, because it often tends to sort of have symptoms that might mimic, for example, irritable bowel syndrome or excessive amounts of anxiety accompanied by a racing heart. So it's very hard to diagnose and thereby making treatment all the more difficult because of the similarity to other medical illnesses. And yeah, emotional behavioral responses must be taken into consideration. Body dysmorphic disorder, obsessive compulsive disorder, illness anxiety disorder are certain things that it can get confused with. And also other functional disorders with unclear etiology, such as fibromyalgia, irritable bowel syndrome, that do not typically manifest with excessive thoughts. Like, I don't know who might be obsessively thinking about their bowels. But basically, what we're trying to look for is trying to make specific distinctions that show up in the client. And something that I've been thinking of is also like, that brings me to my conclusive thought as well, is just how when clients come into sessions, they also have their somatic representation of how they hold their bodies. And oftentimes, what ends up happening is there's a defense cascade and a mechanism that tends to sort of unconsciously show up within the therapeutic process. And I think it's really important to use that therapeutic alliance to really see and slow down maybe the gestures of what the client is doing or holding, where maybe the shoulders are really rounded. And this is based off of William Reich's character structures and defense cascade analysis, which explains how body stores trauma in different ways and how it manifests as aches and pains across the body. And I've written some of which, but a lot of which cannot be medically diagnosed. Oftentimes, there is a scoliosis or change in spinal alignment due to the way we hold tension in our bodies. And people tend to have like humps on their necks, for example, that create spondylitis or a crooked spine. And I do see how an individual that's been affected by trauma can carry the imprints of having gone through that trauma within their body. And its effects might communicate itself or manifest itself a lot later in the client's life. And it's important to keep an open perspective when working with clients. However, I do feel in terms of treatment that I mentioned earlier, where medication was recommended, I do think that somatic body psychotherapy can help clients understand and distinguish each of their symptoms that are arising within their experience of trauma. Yeah, so thank you so much for listening to me. I would love to hear your thoughts in the comments about what you think about this diagnosis. Yeah, bye.